Hello, I'm Cornell Clayton. I'm the director of the Thomas S. Foley Institute at WSU. And on behalf of the Institute, I want to welcome you out to our event today. We're going to be looking at the ethics of allocating healthcare during a crisis. This is our first virtual event at the Foley Institute, and I want to thank those who helped us set it up, especially our assistant director, Richard Elgar. And I also want to ask for your patience if we have any experiences while we film this. The discussion is being live streamed to our YouTube station, and many of you are watching on YouTube. I encourage you, if you have questions, to send those to me at tsfoley@wsu.edu. Again, that is tsfoley@wsu.edu, and we should be able to get to some of these questions later in our discussion. We all know by now that the world is experiencing a healthcare crisis brought on by the COVID-19 pandemic. Throughout the world, healthcare systems are being taxed and pushed to their brink. In Italy, France, Spain, and elsewhere, patients are dying as they wait to get into overcrowded hospitals and ICU facilities. Here in the United States, the Society for Critical Care Medicine has estimated that as many as 900,000 ventilators may be needed when the nation only has 200,000 of these. Although there is recent evidence that social distancing has begun to flatten the curve of the infection, what once seemed unthinkable may still become a reality here. Medical officials across the country are now scrambling to review policies on rationing medical care during a crisis. In general, such plans seek to bring the most benefit to the greatest number of people and prioritize those who have the best chance of recovery. But exactly how that takes place is fraught with ethical questions and issues. The State Department of Health in Washington has established a set of crisis standards of care for how individuals will be evaluated for access to such things as ICU beds, ventilators, or other scarce medical care should these become limited. Some groups, however, complain that these guidelines could lead to discrimination against the elderly, the disabled, or others with underlying health conditions. So how should we allocate scarce medical care and resources during a crisis? And who should make these decisions? Fortunately, we have with us today two leading experts who can help us sort through some of these issues and answer some of our questions. Carl Heine is Associate Professor and the Clinical Education Director of the Emergency Medicine at WSU's Elson S. Floyd College of Medicine. He is a practicing emergency medical doctor with special interest in healthcare policy, environmental issues affecting health, and medical ethics. Bill Kabasenche is a clinical professor of philosophy in the School of Politics, Philosophy, and Public Affairs, and a fellow in both the Center for Reproductive Biology and the Center for Integrated Biotechnology at WSU. He is also the Ethics Education Director of the Elson S. Floyd College of Medicine. So we're going to begin the discussion today with Dr. Heine, who will provide a brief overview of the medical issues involved in today's topic. He will be followed by Professor Kabasenche, who will offer his thoughts about the ethical questions that are raised. And after that, we'll have some time for some discussion. Again, if you have questions you would like to ask, please send those to me at TS, as in Thomas S. Foley, @wsu.edu. So now, gentlemen, I'm going to turn the time over to you, and I will be back later with some questions from our live audience.
Thank you, Cornell. As I was introduced, I am an emergency medicine physician. I practice here in Spokane, Washington. And the medical challenges of trying to allocate the healthcare resources in a way that's going to be most equitable and of the best benefit to the majority of people is really a challenging situation in light of this pandemic. We have, and I have experience and I have training in allocating resources when there are other mass casualty events, a bus accident or something where there's more patients than our system can quickly handle. But in those sorts of circumstances, there's fairly easy triage protocols that can be followed that can help the EMS providers and the emergency department use the resources that they have to the best benefit of the majority of patients. This is a different situation in that we have we don't have neighboring facilities, and we don't have a short-term event that we can easily get through by working hard for a couple of extra hours or a couple of extra days. This is a global pandemic where our neighbors are also going to be out resources, and we can't rely on their assistance in taking care of the patients. And it's an evolving event, disaster that happens fairly slowly. In a bus accident, we have an overwhelming number of patients that would come to the emergency department in a fairly short time. In this kind of a situation, what happens is, normally at the hospital I work at, we intubate a couple patients a week. They go to the ICU, they're on a ventilator, they usually come off a ventilator for whatever outcome they have in a couple of days. In the COVID patients, the patients come in at a different rate, and we, instead of a couple of patients a week, we might intubate a couple of patients a day. And then we have those patients on a ventilator for 10 to 20 days before we know what the outcome is. When you have a couple patients a day coming in, all of a sudden your ICUs become very full of patients, and now we have a resource allocation problem. It's not just the machines, and it's also not just the beds in the ICU that are the limited resources. We will have scarce resources in terms of the medications that we use for these patients. We've already been dealing with shortages of medications even prior to the COVID pandemic. And it becomes difficult if we run out of the medicines that are required for sedation and intubation to also provide care. But the other resource that I think is also really at risk is personnel, is the staff in the hospitals to manage these. Patients with the COVID virus infection that are intubated are complicated respiratory patients. They require fairly sophisticated protocols as to how to help manage them to give them the best chance of survival. This requires a team of both intensivists, respiratory therapists, nurses, and the other support staff at the hospital. When we run out of beds, we run out of, we can make another facility, we can try to make some beds in some other kind of setting. We can try to make more ventilators, but we still need to have the staff that can manage that and help care for these patients. So there's a number of different healthcare resources that are potentially going to be limiting what we can do for all the patients that come that may need help. Fortunately, here in Spokane so far, we have not seen an overwhelming number of patients that need to be admitted or put in the ICU. We've been able to keep up. That is not necessarily true in other parts of the world. My colleagues in New York tell me a very different story about running out of resources and running out of staff and really having a very difficult time keeping up with the demand. And this is part of why the social distancing and trying to reduce the number of infections that happen all at once is so critical for our ability to continue to take care of these patients. The other thing that's really hard is most of the time we allocate resources so that we can provide good care for everybody that presents to the emergency department. If we get to this point where we don't have enough resources, we're going to have to start making decisions that are really going to be hard, because some people that could be cared for and could survive, we may not have the resources to help them get through this. That doesn't mean we would abandon patients. We will still care for patients, but we may not be able to help them survive the outcome. We may be just providing palliative care and comfort care rather than being able to intubate them, put them on a ventilator, and give them a chance for recovery. Trying to make these decisions as to how to allocate those resources is going to be really challenging for a couple of reasons. One, which Dr. Kabasenche will talk about, are the ethical choices and how we make those choices. But also is just the practical part of it. And how do we know how best to use those resources? How do we know how to decide who has the best chance of survival and what kind of care will make a difference in their outcome? In a disaster situation, there's 3 phases of our understanding. In the beginning phase, which we passed, we don't really know much about what's going on, and we're just trying to take care of what we see happening in the background. And in a year or 2, we'll have really good data on how COVID patients respond to various treatments and various interventions, and we can make decisions that are informed by good information and good data. Right now, we're having to make a lot of decisions without good information. We don't know what kind of treatments really make a difference. And we're trying to figure out how to provide the best care we can with limited data. We don't know how to decide who has a good outcome, potential for good outcome versus not. And until we get a lot more experience, we're going to have a hard time making really good decisions based on good data. So we will have medical challenges to make decisions, and we will have some very significant ethical challenges to how to make decisions to allocate these resources during this pandemic. I'll turn it back over to Dr. Kabasenche for his comments on some of the ethical challenges that we'll be facing, how to address that.
All right, thank you, Carl. This is the 3rd occasion I've had in just the past week to talk about these kinds of issues, the ethics of allocating scarce resources. And I've decided that the most appropriate way for me to start each time is with expressing my thanks to all of the healthcare providers who are on the front lines doing the hard work right now of trying to care for lots of people who are very sick. I've been quite moved seeing footage of people in New York coming out on their balconies at 7 o'clock each evening and offering a round of applause. And so I want to sort of join that and express my gratitude to everybody who's involved in providing care to people at this crisis moment. So I'm going to begin by describing 2 very different ethics. And one is the familiar day-to-day ethic that healthcare providers are, for the most part, very comfortable with and use on a regular basis. And the other is the kind of ethic that emerges in a time like this, where we have a public health crisis, a pandemic, and it calls for a very different way of thinking. But then I'm also going to describe what I think is a very uneasy relationship between these 2 ethics. So on the day-to-day, physicians and other healthcare providers use what I'm going to call a clinical medical ethic. And that ethic is characterized by, number 1, the fact that it's patient-centered. It is committed to respecting the autonomy of patients. It's interested in identifying what a patient's or a patient's family's goals of care are. And it's committed to maintaining fidelity to patients. It embraces values like not abandoning patients, promoting their well-being as much as possible, and a variety of other kind of related commitments. And so that's the sort of ethic that, again, healthcare providers all over the world use all the time on a regular basis. However, in a public health crisis like this one, a public health ethic starts to emerge in the conversation and become a necessary part of our thinking. And a public health ethic is characterized not by an individual focus, but by a society-wide focus. And it's interested not in individual interests, but in collective interests, the interests of all of us thinking as a society. It's committed to the good of the whole. It is committed to preventing as many deaths as possible, although that's in a context where we understand in a public health crisis that there will be deaths, more deaths than we would experience during our day-to-day lives. A public health ethic, as I understand it, remains committed to the moral equality of all persons, but it does look for, because it needs to, different ways or ways of treating patients differently, or ways of identifying which patients should be treated differently based on a scarcity of resources and an underlying commitment to promoting the good of the whole. So as you might suspect, during a public health crisis like the one we're facing right now, that public health ethic starts to come to the fore, and it becomes the primary ethic that has to be used at least at a sort of high level for those who are thinking macroscopically and collectively about the interests of society. And I think it's really important to recognize just how uneasy a relationship there is between these two ethics. One of the certain outcomes of a public health crisis, among many other things, is that there will be a great deal of moral distress experienced by healthcare providers, because they're going to have to, in certain ways, set aside the clinical medical ethic that they're used to using, which entails a whole bunch of commitments to their patients that they're used to inhabiting and living out of. And they're going to have to start using, to a certain extent, a very different kind of ethic. And so I think it's important to recognize the distress that this causes, asking a clinician to consider removing a patient with whom they have a physician-patient relationship from a ventilator to put another patient on it because that other patient has a better prospect for survival in the near term, is an incredibly emotionally wrenching sort of decision. In fact, the Washington State Department of Health actually recommends that a triage team should be identified separate from the frontline providers, not because it will be easier for people who are a little bit removed from the situation. It won't necessarily be any easier for them, but perhaps that creates a little bit of distance and allows people on the front lines to try to retain as much as possible of a clinical medical ethic and a first order relationship with their patients. For those of you who are familiar with the history of ethics, you may hear echoes of Immanuel Kant and a deontological approach to ethics in the respect for patient autonomy that's at the center of a clinical medical ethic. And you'll probably hear echoes of utilitarianism coming from folks like John Stuart Mill and Jeremy Bentham in the public health ethic. And I do want to say that although in an ethics class, these theories get talked about a lot, my own view is that there aren't a whole lot of pure utilitarians and pure Kantians out there. And one of the reasons that I suspect that this is the case is because for Kantians and utilitarians, there are actually very rarely scenarios where they experience a moral dilemma. For instance, on a utilitarian view, there is only one, or at most a tie at the top, among the courses of action that will produce the best possible set of consequences for all involved. And given that, there's only one option to take, and someone who's strictly committed to a pure utilitarian view really doesn't feel any kind of dilemma, because once they've identified the one right course of action, they immediately recognize that that is in fact the right thing to do. But in the real world, most of us experience a great deal of emotional distress contemplating the prospect of having to prioritize one patient over another in a scenario where we know if we had enough resources, we could save both of them. And so that actually brings in a third approach in ethics, a virtue-based approach. And that approach really attempts to articulate the virtues and characteristics of a person who's attuned to all the different nuances of human life and what makes it go well when it's going well and what makes it difficult and challenging when it's going difficult and challenging. So someone like Aristotle, an ancient Greek philosopher, would actually say that the appropriate thing to do is to have emotion dispositions that attune us to feeling the right ways at the right times toward the right sorts of things. And I think most people would recognize pretty quickly that the right emotional response to the prospect of having to deprioritize a patient who under other circumstances we could have helped, but allocating that care to another patient who has a better prospect of success is emotionally wrenching and incredibly difficult. And to a certain extent, I want to say for those clinicians who are experiencing that, that is actually, I think, the appropriate emotional response. It's not something to feel bad about. It's actually probably just the right response. So when we think about allocating scarce resources, I think it's very important to keep a focus on what our situation is. We're talking about a scenario where we maybe have two patients. Let's call them patient A and patient B. And both of those patients could benefit to some extent, or at least we have some reason to think that they could benefit from being placed on a ventilator, which is a machine that helps people to breathe when they can't breathe successfully on their own. And when we think about this situation, maybe a physician assesses that patient A is significantly sicker than patient B, such that if we were to put patient A on the ventilator, it's possible that patient A will still die despite our best efforts to try to treat that patient's disease. But on the other hand, patient B has, as best a physician can tell, and this is definitely going to be a judgment that physicians have to make. And as Carl already mentioned, it's a judgment that in this circumstance, they'll have to make in the absence of really good, clear data, unfortunately, in some circumstances, because we don't yet have a real good picture of the long-term prospects for patients living with COVID-19. But somebody will have to make a judgment as best they can, and they might assess that patient B has a better prospect of success if we put patient B on the ventilator. And of course, if we imagine a scenario where we only have one ventilator, that really is the question that's at the heart of the ethics of scarce resource allocation. So there's an awful lot of consensus that in a situation like that, the best thing that we can do in this tragic circumstance would be to allocate the ventilator to patient B. If we were to allocate the ventilator to patient A, what we might end up with is 2 deaths instead of 1. But if we allocate the ventilator to patient B, we have a, statistically speaking, somewhat better chance of having only 1 death occur in that circumstance. And as I mentioned earlier, at the heart of a public health ethic is a commitment to trying to minimize the number of people who die or who experience a significant amount of sickness as a result of the circumstances we find ourselves in. So last week in the newspaper, I read a quote from someone who was expressing a concern about the Washington State Department of Health allocation guidelines. And as part of the quote that was captured in an NPR newspaper article, this person actually said that he was going to appeal to President Trump to stop the rationing. And my first thought when I read that quote is, unfortunately, I think that person doesn't fully appreciate the situation that we might well find ourselves in. We can certainly hope that we don't get there, but we have to think about the possibility that we will get to a place where we're faced with patient A on the one hand and patient B on the other, and only one ventilator to allocate between them. And in that sort of circumstance is precisely when I think we do need to think in terms of, number 1, limiting as much as possible the number of deaths that occur, and number 2, trying to do that in a way that's as fair as possible, despite the fact that we might think that the most fair thing would be to try to preserve everybody's life. Unfortunately, we can't do that under these circumstances, and so we really are faced with a difficult ethical decision of how to reduce the number of deaths as much as possible and how to try to prioritize patients, despite the fact that we might well want to treat all of them if we could. But unfortunately, we can't. So I'm going to stop here and allow our moderator, Cornell Clayton, to come back in and give us some questions. I think we might have some questions coming.
I just want to make a comment. I want to thank Bill for really highlighting that conflict between medical ethics of the individual patient and public health ethics. One of the things I am most fearful of is the moral injury from having to make those kinds of decisions. As a physician, I'm very comfortable doing the best I can for every patient in front of me. Even when there's a bad outcome, I am comforted by the fact that I did what I could to provide good care. I might be sad, but I don't feel like there's something I could have done better. And the moral injury of having to choose which person to take care of and which one to not help will be devastating for many people that have to make that decision. So thank you, Bill, for bringing that up.
Yeah.
All right, thank you both. So I have a couple of questions. Some are coming in from the audience now. Let me start off, though, by asking you both this question about the triage teams. It makes a lot of sense to remove some of these decisions from the principal caregiver and have a more dispassionate body take a look at when we allocate scarce resources. Who typically would serve on these type of triage teams, and who selects those individuals?
That's a great question, and there are some guidelines from the Washington Department of Health as to how to formulate those types of triage teams. I do think it's important that there is an ethicist or somebody who really has a deep understanding of ethics on that team, because there are going to be clinical decision-making as part of that. There will need to be some people that have the medical background, potentially an intensivist, an ICU physician, pulmonologist. But it would be best if it wasn't a physician that was directly involved in the care of the individuals that we're trying to make a decision on. I don't know, Bill, do you have more you want to say on that?
Yeah, no, I think that captures it well. Cornell also asked how those people will be identified. As far as I know, hospitals are doing it on a institution by institution basis. Although that also raises questions about allocation of scarce resources between facilities. You know, you may have a situation where one facility is, in fact, I think that some of the reporting from New York has indicated this is the case, where one facility will be filling up. But allocation decisions don't have to be just within one institution. We could also think about allocating the resources across institutions. And then we would need even a triage team that kind of stands above the two institutions to a certain extent. Right? I mean, it becomes a collective action problem, and it requires collective action to try to solve that problem.
Okay.
I will just add to that. In Seattle, some of the hospitals are pretty overwhelmed with the number of patients they currently have, and other hospitals are helping to take some of the slack up and to have some of the sicker patients transferred to the facilities that do have a little capacity. So there is sharing of resources amongst institutions that is a really important part of our healthcare network in general, and especially at times like this. The really challenging thing is when the whole community is now overwhelmed and you don't have that opportunity as easily.
Yeah. So, one of the controversies regarding Washington's crisis standards of care has to do with the 5 criteria that are suggested that we look at for allocating scarce resources. And one of those criteria is the patient's baseline functional status. And the guidance given on evaluating that criterion is consideration of the patient's loss of energy, physical ability, cognition, and general health. Now, some groups have raised concerns about that particular criterion, that it would lead to discrimination against the elderly or the disabled or others who have underlying health conditions. I wonder if the two of you could talk about that, how it would be evaluated in practice, and what are the ethical concerns there?
Well, I can go first and just say something about the ethics. I mean, first of all, it's the last of the criteria. And so as I understand it, the hope is that we could use the other criteria first so that we don't have to use this one, because it's definitely one of the more ethically controversial ones. It raises the prospect of discrimination. I mentioned earlier that even in a public health ethic, there is generally a commitment to promoting the moral equality of all people. So if people are treated differently, we're hoping to find some sort of principled basis on which to do so. There's a lot more consensus. There's actually, in the past decade or so, there's been a number of surveys conducted and focus groups conducted. And there's a lot of consensus that if it came to it, prioritizing patients with better prospects for short-term survival, that generates a lot of agreement. However, long-term survival prospects, the sort of underlying conditions, not underlying conditions that might affect immediate survival, but underlying conditions that might affect survival 5 or 10 years out, those are much more controversial with members of the public. I would say that if it came to a place where we were using those, we would need to recognize that it has to be grounded ultimately as much as possible in a commitment to trying to keep it grounded actually in that original ethic of we're trying to allocate the resource where we think it can do the most good. But it would be really unfortunate if we get to a place where we start assessing people not in terms of their immediate survival prospects, but in terms of the overall quality of their life. And it's especially dangerous, obviously, when other people are making that assessment. maybe at the very least, if we were to get to a place where we're attempting to do that, we should have representation on triage teams from people within disability communities, or maybe representation from elderly communities as well, to ensure that there's at least a voice in the room that is advocating for those people as much as that can be done under the circumstances.
And I think that brings up the importance that there's an ethicist on these triage teams, so that, and I echo Bill's comments that we do need representation from the different kinds of groups that would be affected on that. Medically, I feel very comfortable making a decision who has short-term survival odds, but it becomes much more difficult when we're talking about longer-term predictions of outcomes and quality of life and those sorts of things.
So a student in Pullman named Julia has a question about the use of students who have not fully graduated from medical school yet, but they're being called to the front lines to start assisting in places like New York and elsewhere. Are there ethical concerns there about if these would-be doctors or new doctors make mistakes because of their lack of training?
Sure, and let me give an explanation of how the medical education system works as a whole, because this kind of addresses this. We have a system to educate physicians that is an apprenticeship type of model, where we start off with giving doctors in training very little responsibility, but a lot of oversight. And as they go through the education, the amount of oversight they have is reduced as their responsibilities go up. So when you're a student, you've got almost no responsibility and complete oversight for all of the decisions you make. And when you graduate from medical school and you start your next phase of graduate medical education or residency training, you now have some responsibility and some oversight. And as you go through residency, that switches. A student who graduates a month early from medical school will then still go into a residency type situation where they would have a little bit more responsibility than they would have that month in the more traditional model where they would have finished out the rest of their fourth year. But there still would have some oversight by practicing attending physicians. But what we're doing by having those fourth year medical students finish a little early and start residency a little bit early is we're increasing the number of people that can help with managing some of the work. The decision making that these recent graduates or new graduates or early residents would be making would be not the life-threatening and who gets the care and so forth, but it would be on the more basic levels of care. So I don't think that there would be any real uptick in poor outcomes if you graduate a fourth year medical student a month early versus what would ordinarily happen with our apprentice style medical education system.
Okay. Bill, I have a question for you from one of our audience members, Matt Carroll.
Yeah.
He asks whether your scenario between patient A and patient B change at all if one has a greater life expectancy independent of the immediate situation. In other words, is some rough calculation of years of life saved relevant here?
Yeah, so that's the underlying condition sort of concern. And again, there's much more consensus on prioritizing patients with immediate prospects for survival. And I think part of that assessment could include, so for instance, we're learning that hypertension and diabetes are two conditions that seem to be closely correlated with increased death from COVID-19. So as a triage team is assessing patients, if they have limited resources, if they were to find that a patient does have one of those underlying conditions where we have, it's still, I think we should consider it emerging evidence, certainly not conclusive evidence. But where we have emerging evidence that suggests that that might be a reason to think they would be less likely to survive. In the short term, I feel pretty comfortable with using that kind of information, at least as comfortable as we can be in what is an overall deeply uncomfortable situation. You know, as Carl was saying, when we start to speculate about the longer term survival prospects, you know, maybe somebody is early in a diagnosis of cancer, but you know, there are some forms of cancer you can live over a decade with. And so I guess I would say that we should be much more wary of using those longer term survival projections. I'm much more interested in using the short term survival projections as much as possible, just because number one, I think that physicians and others are in a better position to make a good clinical judgment about those kinds of cases. And number two, I think that preserves as much as possible our commitment to the moral equality of persons, which would, other things being equal, have us committed to doing everything we can as much as possible for all patients.
Great.
There's obviously lots of press about the mortality statistics of the COVID patients, but I read recently an article about I think it was a 101-year-old gentleman that got COVID that recovered and got to celebrate his 102nd birthday. So it's hard to make these choices. So
yeah,
that's a happy story.
Cornell, can I throw in
some happy story in here?
Yeah, go ahead, Bill.
I just want to throw in one more idea, and this is actually another question that I'm seeing emerge in the chat. As we think about allocating health care resources in a condition of scarcity, it's not just COVID-19 patients, it's all patients, and they really all need to be thought about collectively. So for instance, right now, Pullman Regional Hospital has canceled all elective surgeries, and it's suffering financially for doing so in an effort to be as prepared as possible to treat COVID-19 patients in this community. But there are still going to be car accidents. There are still going to be people who have health emergencies unrelated to COVID-19. And so when we think about these resource allocation decisions, we really do need to put them all in a pot together and think about the immediate and near-term survival prospects of all of those patients. Patients with COVID-19 should not get special prioritization just because they have the condition that everybody's talking about at the moment. When we make these decisions about scarcity, unfortunately, we have to think about everybody. We are all, even those of us who are not currently suffering from COVID-19, we're all living in an environment where healthcare resources are very scarce. And so we need to think about all those decisions together, not separate them out and suggest that there's a separate entryway into the hospital for patients who don't have COVID-19, even though there literally is a separate entryway into the hospital for those patients.
Yeah, I also want to add that it's very interesting. The majority of the patients I have been seeing recently have not been COVID, and I've been giving them the same kind of care, whether it's a heart attack or a stroke or appendicitis. But we are seeing, because of the social distancing and some of the requests to reduce activities, we are seeing fewer other kinds of injuries. People are driving less, which is reducing the number of car accidents. We are asking people that do high-risk activities to limit those so that we don't stress the healthcare system beyond what it currently has. The other feature on that is we want to encourage people to not be scared to get the care that they need just because there is a pandemic. I mean, I've heard of people with crushing substernal chest pain that don't want to go to the hospital because they don't want to get COVID, but I'd be very worried about a cardiac event. And so we really want to make sure that we do take care of everybody and every medical condition that we can.
Great. So another question is, it's one thing to talk about making decisions of who gets a ventilator. There's a separate question about how we decide to remove individuals from ventilators or from life support. And traditionally, when we make these decisions, family members are consulted and involved in that decision, as are advanced care directives by the patient themselves. And I wonder how this process would take place in the event of a crisis that overtaxes the system. Are these completely superseded, or is there still some role for advanced directives and for family members?
So before we get to the point where we have to take a ventilator away from one person to put a new person on that ventilator, I think that we should be consulting with families and individuals about their last wishes. And I have seen a number of comments from colleagues in emergency medicine or other physicians about, you know, how they would want their care to be delivered in terms of, you know, their decision making on their behalf. The real challenge comes when I have a patient that I think will have better chance of outcome by giving that person the ventilator, and I don't have another ventilator I can give that person, and I have to actually take a ventilator away from somebody that hasn't made that indication or request to give it to a patient that has a better outcome. That's a horrible place to get to, but I think that in the public health ethic that Bill talked about, we do need to be thinking about what is the best outcome for the greatest good for the greatest number of people. And I think that the public health ethic would then supersede the individual ethic at that point. But I think Bill might have more to say on that.
Yeah, I mean, that patient A, patient B scenario that I described earlier, that's not just two patients waiting to get on a ventilator. In some cases, that's maybe patient A is already on the ventilator. And so a crisis of healthcare resource scarcity is, as Carl was describing earlier, it's a long-running event. And it's not the case that getting your hands on a ventilator means it's yours for life. So for instance, the Washington Department of Health is actually recommending reassessing patients every 24 hours in an effort to try to identify, if necessary, those patients who should be deprioritized for continued care, or at least continued ventilator care. As Carl was saying earlier, we should continue to care for patients in the sense of providing palliative care, but we might not be able to provide curative or therapeutic treatment to all patients. And that might actually create a scenario where we remove someone from a ventilator, but that is really an extension of that patient A, patient B scenario I described earlier. And if the fundamental underlying commitment is to limit the number of deaths as much as possible, then that will mean in some cases taking a ventilator from someone who's likelier to die and giving it to someone who's less likely to die in the near term.
So I have another question from the audience, and that it's a broader philosophical question, and that is how we should think about the ethical questions we're raising right now with respect to a crisis, and think about those in more normal times. So for instance, right now in the United States, we spend an enormous amount of our resources for patients who are at the end of their lives, and relatively very few resources on people at the beginning of their lives, for children. Should we apply some of these ethical standards we're discussing right now that prevail during a crisis in normal times? Bill, that might be one for you to start with at least, and then maybe Carl can.
Sure.
Yeah, that actually sounds like something a student might have heard in one of my classes. You know, I would say that we should not. Well, first of all, there's a certain way in which rationing does occur, even in normal circumstances. Sometimes it's just a matter of the number of patients that a physician can see in a day. And, you know, that means that for a patient who's further back in the line, they're not going to get seen that day. So again, for those people who say we should not ration under any circumstances, I'm deeply sympathetic in the sense that I think we should avoid rationing wherever we can. But we also need to recognize that we have limited resources even under the best of circumstances. I don't think we should embrace a full-blown public health ethic. It is an ethic for an emergency circumstance. And one of the things that we need, I mean, there are different things that we could ration. We can ration in an effort to save lives. We can also ration in an effort to save money. right now we're rationing in an effort to save lives, or at least that's the prospect we're facing if the coronavirus spreads in the United States the way it has in places like Italy and China and South Korea and Spain. So the prospect of significant numbers of people dying is a reason to shift to a public health ethic. The hope to save money that would then be allocated to vacations, that's a very different sort of allocation kind of decision and a different way to make prioritization decisions. My own view is that, well, number one, we have good research to indicate that we could save a significant amount of healthcare expenditures, again, during normal times, if we could identify and encourage providers to stop giving treatments that don't actually have a proven benefit. You know, this is sometimes referred to as overtreatment. By definition, overtreatment is care that does not provide a benefit to the patient, but of course it still carries all the risks associated with it. And so wherever possible, we should try to identify and discourage overtreatment. And there are estimates that we could save up to 1/3 of our current healthcare costs if we did so. I would say we should try to do something like that before we even contemplate using a public health ethic in a non-public health crisis.
Yeah, I actually have a lot I could say about that question, but it's more of a health systems question and how to design an effective healthcare system that delivers the best benefit for the population as a whole. And I would echo the concern that we don't have a very effective or good overall health system in this country, and that we do have people that get poorer quality care because of economic distributions and other allocation decisions. But it's not so much an ethics question as is an economics, systems, and political question as to how we distribute those resources. I would love to see it a little bit more equitable, and I think we do provide too much care to some people, and by doing that we cause harm. We also provide too little care to some parts of the population, and we certainly cause harm with that. And I think trying to redistribute that in a way that does a better job of our population health would be a great step forward, but that's a very difficult economic and political question, more so than an ethical question.
Although I will point out that at the heart of it, there is an ethical question, and it's this. Sure. Should we as a society provide access to basic health care for all members of our society? That's an ethical question. And that's the one that the US has punted on, whereas every other developed country in the world has not. They've committed to it, and we haven't. Okay. If there's anything good that might come out of this pandemic, it might be that people in the US will become more sympathetic to providing access to basic health care for all members of our society. I certainly would consider that a good.
Yeah.
So I have a more practical question from one of our student audience members, Connor. He asks about, should we be concerned about the fact that there are a lot of medical personnel right now, doctors, nurses, and others, who are working in ICU and emergency room conditions who aren't used to working under those conditions? Should we be concerned about that? And do they get any additional training, especially about some of these ethical issues before they're dumped right into the process?
I can't speak to their training and the ethical issues. All physicians will get some amount of ethics training in medical school and hopefully during other parts of their educational system. I do know of a number of specialists that, yesterday they were a cardiologist and today they're an intensivist. I knew of a nurse who was a family practice nurse and a family practice nurse practitioner who's now an ICU nurse practitioner. And the level of training that they get to make that transition kind of depends on how much time and resources there are to help those folks. But we're trying to allocate that scarce resource of healthcare personnel in to settings where it can do the most good. And while yes, a pulmonologist, critical care ICU doc would be the most talented at taking care of patients, a cardiologist or a surgeon that can try to help with that is certainly better than not having anyone. So.
Okay, thanks. Listen, I think our time is starting to run out. I'm just going to ask both of you if you have anything you want to add to our discussion.
I think continuing to answer the questions, I think, is most useful at this point here. There's been some really good questions. I don't know. What do you think, Bill?
I'm good with that. I was gonna ask if you wanted to speak at all to the question of whether healthcare providers have a moral responsibility to
sure.
care in a time like this, in a pandemic. I think that's worth talking about a little bit as well.
Yeah, that's a great topic that hasn't come up in the questions yet, and that's that is a hard question to answer. We do have a social commitment and a contract with society to provide care. Society has granted us great privilege by educating us to be care providers. They've given us some level of respect for being physicians. And we do owe it back to society to provide care in difficult times. We do owe it back to provide care during a pandemic, but it's a two-way street. Society should also make sure we have the equipment we need to do that care and to do it safely. By that, PPE. It's a little bit of a disservice to the healthcare community that we don't have an adequate supply of personal protective equipment, masks, gowns, gloves, face shields, because that reduces our risk of getting infected. The other challenge is it's not just the physicians or nurses, it's their families as well. And while I have a contract that I should be taking care of patients, I'm also exposing my family to a higher level of infection risks than if I wasn't doing that. And what's the ethics there? In the decision making, historically, there were times when physicians did flood communities, urban areas during pandemics. The best example is Galen, who was one of the founding fathers of medicine, did flee, I think Athens was it, or wherever he was, to the countryside to avoid getting infected during a pandemic. And so there have been a number of times and examples when physicians haven't stood up. But I think one of the things we are seeing right now is that the healthcare community is stepping up. They are coming into work. They are, doing the best they can with limited protective equipment. Some of that also depends, another good example would be, do you expect a fireman to run into a burning building if he doesn't have a breathing apparatus and the special clothing that they wear to protect them from a fire? At some point you would say that's foolhardy and that's not a really good use of resources. Because you also get to a point where if the healthcare community is suffering great losses, then there aren't people left to take care of and provide the care. So at some point, there's a foolhardiness to running in and providing care if the chances of adding to the patient burden becomes too high. And it's a really interesting question. Right now, the COVID mortality rate, there's a lot of debate as to what it truly is, but is it 1%? Is it 2%? But it's still a fairly small, not insignificant. That's 1 or 2 people in 100 that get COVID will die. What if that was 50%? What if 50% of the population that got COVID, that was the mortality rate? When does it get to the point where the risk and the depletion of trained healthcare professionals becomes a bigger problem and a bigger burden to the system than, the benefit we get from providing that care.
All right. Well, listen, I think our time is about run out. I want to thank both of you for participating with us today in this discussion. I also want to thank our audience members for tuning in. And finally, I want to join Bill, and I'm sure Carl as well, in thanking our healthcare providers for all that they are doing during this crisis and helping us. Let me encourage all of you to look forward to our next events. We hope to be doing a couple of more of these virtual events before the end of the semester. And again, I thank all of you, and I thank Dr. Heine and Dr. Kabasenche